Hello, good morning. Happy Sunday morning with Sunday morning coffee with Dr. Childress. Today, I want to discuss the forms, uh, some rating forms for various symptom ratings uh, that I have up on my consulting website. The Diagnostic Checklist for Pathogenic Parenting, the Parenting Practices Rating Scale, and the Parent Child Relationship Rating Scale. Now, these forms are not assessments. They are simply data documentation forms because everybody fights about everything over here in the family courts. And so we need to get clarity on the symptoms because diagnosis is a pattern match of the symptoms to the diagnostic criteria. And so we just need to get the baseline of what everybody can agree on are the symptoms involved. And then we can apply the diagnostic criteria and see what lines up. The difficulty is when last time, so I came up with a set of symptoms that three symptoms, three diagnostic indicators that will always identify the pathology and will never misidentify anything else as the pathology. So these three symptoms will absolutely identify if they are present. There's no other explanation for these three symptoms than the pathology I describe in Foundations, the cross generational coalition, the shared persecutory delusion, factitious attachment pathology. I wish I could call that like a label, but the moment I start to call it a label, people will say, I have a new theory. Okay, so the moment we can get past, no, Dr. Childress does not have a new theory, this is the application of established knowledge, then I can shorten that big description, shared persecutory delusion, factitious disorder, dark personality, cross generational coalition, emotional cutoff. I can shorten all of that to a label. The label I've started with attachment based parental alienation, ABPA, but we can call it anything anybody wants. It's just, it is not a new theory, it's the application of knowledge. And so um, with this, as I because I'm competent in the assessment of delusional thought disorders, and I'm competent in family systems therapy, and I'm competent in factitious disorder, and just to the attachment system and attachment pathology. So I know all that stuff. And now these mental health people in the family courts do not. They are ignorant like a rock. They don't know how about delusional thought disorders or family systems or attachment pathology or nothing. And so all of them, all of the forensic psychologists, the people in the family courts, are practicing beyond the boundaries of their competence, violation of 2.01. And that's creating a nightmare mess for you parents because you don't have any competent mental health people in the family courts. Now, the problem is where the competence is out in clinical psychology, they won't work in the family courts because it's too dangerous. So the moment we get rid of the incompetence in the family courts, there's going to be no mental health people. So that's what we're headed into: is there will be no competence in the family courts. Now I am what's called scaffolding the transition up to mental health competence with these various forms and with an attachment based model. I've kind of spoon feeding the mental health people the information that they need. But really, as I was waiting, I was looking at one of my books here, Mastering Family Therapy with Mnuchin, or Family Evaluation with Murray Bowen. They need to actually be going to the real stuff, and all the way up to Daniel Stern and intersubjectivity and the neurological networks. They need to be going to the actual knowledge. But until they get there, I'm helping them. I'm scaffolding through this situation. And so I've applied all this knowledge, and I've identified three symptoms that will always be present when the pathology is present and will never be present if it's not the pathology. So they will absolutely identify this. The problem is, last time I asked you to go out, you parents, to go out and get these ratings from the diagnostic checklist, to get these ratings from your mental health person, just say, here, can you please fill this out for me? They would retaliate against you. They would say, no, I'm not going to complete this. And then they'd write nasty letters to the court about how you were being uncooperative with their treatment. So I stopped asking parents to ask their mental health people to document what the symptoms are because you would face retaliation from the mental health people. Now that, holy cow, that should never, ever, ever happen. It should never happen that you have to explain a pathology to the doctor. The patient shouldn't have to explain a pathology to the doctor. The doctor should already know the pathology. Holy cow. Okay. The but they don't. You're in this position. What happened though, when you would give them this, you would expose their inadequacy, that they didn't know the attachment, and you're kind of backing them into a corner on their ignorance and exposing their ignorance. And so that creates a narcissistic injury, it's called. Yes, they have narcissistic personality pathology. The mental health people in the family courts, especially the forensic psychologists, actually all of them, the Gardner PAS people and the flying monkeys and all of them, are kind of pathological in the family courts, the mental health people. The mental health people in the family courts are also child abusers. It's a nightmare over here. And when you would provoke the narcissistic injury and they retaliated against you, I had to stop asking you to complete this. But I've reached the point now that I'm in the family courts and potentially I can start defending you against retaliation, and we can start going after people's licenses and stuff. And so now ask them again. Start asking. This should be routinely completed, routinely, by all mental health people in the family courts. There is no reason not to complete the diagnostic checklist for pathogenic parenting. Even if you don't agree with Dr. Childress in this whole thing, complete it anyway. Let's see what your opinion is about these three symptoms. And it's written kind of a lot of words and definitions here, but it's really very, very simple. The reason it's so complex in its writing is it's called an operational definition. I operationally defined each one of these three constructs. The third one is on the second page here, the delusional disorder, in order for research purposes. And so this is a wonderful research instrument because it defines the population. So, for example, on the Greenham Childress Pruder article that looks at the 12 associated clinical signs, which are on page 3 of the diagnostic checklist, so the 12 associated clinical signs, that Dorsey tags for these in our custody resolution method. So she has all this data that identifies this in families. And so in 46 families that had the 3 diagnostic indicators, Melanie, myself, and Dorsey were able to work up how often would we see these associated clinical signs in these 46 families who had this. So these 3 diagnostic indicators define the population. That's the operational definition for high conflict divorce or parental alienation, is the 3 diagnostic indicators. If that's there, that's the pathology. If they're not there, it's something else. I'm not trying to solve everything on the planet. We're trying to solve this particular thing. Shared delusional disorder, factitious attachment pathology imposed on a child. So the 3 diagnostic indicators actually go along with Bowlby's 3 volumes. Diagnostic indicator 1 is volume 1, attachment. Diagnostic indicator 2 is Bowlby volume 2, separation, anger, and anxiety. And volume 3, loss, grief and loss, is diagnostic indicator 3. That's the delusional disorder, interestingly. But so these actually mirror that. And that's why there's 4 of them instead. I say there's 3 diagnostic indicators, but we're really gonna, number 2 is kind of a double one. So the first one is really simple. And all three of these are impossible symptoms. Okay. They never show up anywhere. And that's what makes them interesting and valuable diagnostically. They only show up with this pathology. They never show up anywhere else because they're impossible. The first one is a child rejecting a normal range parent. Is that present, absent, or somewhat? Give me an answer. Is a child rejecting a normal range parent? Attachment system suppression towards a normal range parent. Now, how do we define a normal range parent? Well, that's your parenting practices rating scale, and we'll get to this in a second. But that's the companion piece for the diagnostic checklist. And so this one is do we have a normal range parent? We'll get to that in a second. But the first one is a child rejecting a parent. You can write that on a napkin, and that's the simple question. Is a child rejecting a parent? Yes or no? Yes. Is it a normal range parent or is it an abusive parent? Becomes the next question. The second diagnostic indicator is the child's symptoms. And we're either going to have high anger expression or high anxiety, off the chart domains. And that's Bowlby Volume 2, separation, anxiety, and anger. And so we're going to have one of those two. They're called protest behaviors, but extreme levels of it. Now, how do we identify that for diagnostic reasons and for research reasons? How do we operationally define high anger and high anxiety? Some people say yes, some people say no. We need to stop the fighting. So the way I defined the high anger was 5 narcissistic personality traits in the child. Absence of empathy, very concerning. Splitting, those two will define the narcissistic personality somewhere. Absence of empathy, splitting, entitlement, a haughty and arrogant attitude, and grandiosity, and sort of judging the parent. So you're going to find 5 specific narcissistic symptoms and or a phobic anxiety in the child. And it's going to meet DSM-5 diagnostic criteria for a specific phobia. Okay. So avoidance of the stimulus of the parent, panic attacks, even thinking about being exposed to it can produce a panic attack, that sort of thing. The 3 symptoms of a specific phobia. But it will be a mother type or a father type, a mother phobia or a father phobia. That's impossible. It's impossible. We have never had ever a single case of a mother phobia or a father phobia because the attachment system prevents that. And so that doesn't happen. The narcissistic personality traits in the child doesn't happen because narcissistic personality disorder is an adult pathology, not a child pathology. In childhood, it's an insecure attachment. It only crystallizes into the personality pathology as the child moves to adulthood. As the brain crystallizes out its personality or coalesces its personality as it moves to adulthood, that's when we get the personality pathology. Prior to that, it was an attachment symptoms that we're going to see in the child. So both of those symptoms in a child are impossible symptoms. Child doesn't reject a normal range parent ever. Narcissistic personality disorder pathology is not possible in a child. Mother phobia or father, not possible in the child. But guess what? If you look, you will find them here. So ask the mental health person, is a child rejecting a normal range parent? And then ask them, am I a normal range parent? Rate what my parenting on this parenting practices rating scale. And so document whether you think I'm normal range or aberrant and abusive of my child. Let's get clarity on that. Because if I'm normal range and I have a child rejecting me, that's not possible. Okay. You have to explain why a child rejects a normal range parent. Doesn't happen. Next, how does a child acquire 5 narcissistic personality traits? It's not from the psychological control of a parent who has those traits. So those are what I call the psychological fingerprints of the psychological control of the child. The fingerprint evidence. We cannot control a child without leaving our fingerprints of our control. That's the narcissistic personality symptoms. And the phobic anxiety. You have to explain, how does a child develop a mother phobia or father phobia? It's not possible. If that's true, write it up for a journal, because it's the first case ever. The third symptom, though, is the kicker. Okay, that's the key symptom. It's the persecutory delusion. Does the child show a persecutory delusion towards the normal range parent, towards the parent? Okay. Does the child have a persecutory delusion? Yes, no, maybe. And with the mental health person needs to answer that question, because that's the key question. We need an answer from some mental health professional. Is there a persecutory delusion present? Because if there is, the only answer for that is a shared persecutory delusion. Now, each one of these symptoms is diagnostic by itself. If I have a child rejecting a normal range parent, that's diagnostic of the pathology, because that never happens. The attachment system motivates children to bond, and if it's a normal range parent, you don't see a child rejecting a normal. Even a bad parent, you get insecure attachment that more strongly motivates the child to bond to a parent. The only time you might see a child rejecting a parent is with child abuse. But an abusive parent is not a normal range parent. Okay, so if it's a normal range parent, it's not impossible. So that's diagnostic. Narcissistic symptoms, that's psychological fingerprints. It doesn't show up in the child. A phobia, that doesn't show up in the child. Those two are diagnostic by themselves. A delusional disorder in a child, persecutory delusion. Children don't develop persecutory delusions towards a parent. That's diagnostic in and of itself. But I've given you three of them because they will always show up together. They'll always be there, because I didn't want to put the burden to have a single symptom diagnosis, because the mental health people are just ignorant like a rock. We're scaffolding them up to not the application of knowledge. So I gave them three. So you have three symptoms. If all three are present, then the pathology is present. If all three aren't present, then it's something else, and we can talk about what that something else is. On the third page, so those are just symptoms, please. And the three questions are basically really simple. Is the child rejecting a parent? Is the child displaying high anger or high anxiety? And does the child have a persecutory delusion? Now, it's kind of like the old Sesame Street, which of these three is not like the other? That third symptom is kind of the key symptom. And again, that's a one symptom diagnosis. If the child has a persecutory delusion, then that's child psychological abuse. Now, that's all we need, actually. In DSM-5, okay, look, I'm banged up thing. I have to get my new copy. I guess there's a new revision coming out, DSM-5R, text revision. The 719, page 719, child psychological abuse. There it is. Page 719, child psychological abuse. It's called a V code because all of these in this section, all the code numbers start with the letter V to indicate they're not really a psychiatric diagnosis. All the other ones are, back here, psychiatric diagnoses, schizophrenia, autism stuff. These are not psychiatric diagnoses. They are environmental social factors that influence the psychiatric diagnosis, such as, let's toss back in here, housing problems. Okay, would be one. But here, child abuse. A child being abused doesn't have a psychiatric disorder. It's the world is abusing the child, and that will create the psychiatric disorder or influence it in the bigger book. So they're all called V codes. And so child psychological abuse, V995.51, is the critical diagnosis. The one on the next page is also applicable. Spouse or partner abuse, psychological. That's the core of the pathology. It is at its core a spousal abuse pathology using the child as the weapon. But in weaponizing the child, they produce such significant pathology, it becomes child psychological abuse as well. And because the child is developing, that diagnosis is higher in the dangerousness, higher in the priority list. So I'm focusing on the child psychological abuse diagnosis. We need to protect the child, but we also need to recognize that we have a second dangerous pathology and a second abuse pathology of the spousal abuse that's also present. Now, all we need is the mental health people to have the backbone to protect the child and make the diagnosis. They can do this whenever they want, whenever. That's what their license means. They're authorized by the state because they're licensed to give a diagnosis and to identify child abuse. And they have duty to protect obligations. And they have obligations to the court if they're working in a forensic role to identify, diagnose. Those words mean the same thing, identify and diagnose child abuse when it's present. And there's all forms. There's a sex abuse here, there's a physical abuse over here, neglect down here, and child psychological abuse, four of them. And so they have obligations to protect your children and to protect you. Okay. And that's kind of interesting if you ever file malpractice lawsuits or something. They didn't protect you either. So there's two counts. But all they need to do is make the diagnosis. And all they need for that is the backbone to do it. To protect the child. But they're not. They're not making the diagnosis. And they are applying stupid stuff like parental alienation or resist refuse dynamic that neither one exists, and allows them to avoid identifying what the problem is. It's child abuse. And we can't hold them accountable to those other stuff because it's just made up stuff. They're just we can hold them accountable to delusional thought disorders. We can hold them accountable to a factitious disorder imposed on another, FDIA, 300.19. That is a psychiatric disorder, factitious disorder. It's a false, artificially created attachment pathology imposed on the child for the secondary gain to the parent of manipulating the court and meeting their own emotional and psychological needs. Another long description. I wish we could just kind of package it into a small label. But so the mental health people, we need to hold them accountable because we need to get child protection. And we need some sort of criterion for how we define child psychological abuse so we don't fight about it. So that we don't say, one mental health person says it's child psychological abuse. Another one comes in from the other side and says, no, it's not. It's bonded parenting. And now we have the mental health people in staff splitting, in parallel process, split over fighting about just like the parents are fighting. That's not good. The mental health people should not be part of the pathology. So we need to come together in a single voice to the court. And the way we do that is by applying established knowledge. If all mental health people apply the same knowledge, then we can stop fighting amongst ourselves, amongst the mental health people, about what the pathology is. And that's key, is for the mental health people to come together in a single voice so that we can give the court a single voice and the court can act with certainty and clarity based on that voice out of professional psychology. And the voice of concern is there child abuse? That's the voice that needs to be given clearly to the court. Yes or no. Is there child abuse? Is there a child protection response warranted? And we need to identify that. With severe attachment pathology, number one, attachment, a child rejecting a parent, the only a cause of that is child abuse. So now, is it child abuse by the targeted parent and the targeted rejected parent? And is that then creating the child's attachment bond? That's a two-person attribution of causality. That's what the allied parent is saying. It's the targeted parent who's abusing the child, creating this attachment pathology. The targeted parent is saying, no, 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 it's not me. I'm normal. It's the allied parent who's psychologically abusing the child and creating this shared persecutory delusion in the child. That's a three-person triangle attribution of causality. So now we got two allegations. Both of them are child abuse, and we need to figure that out. We need a proper risk assessment to see which parent is abusing the child, because one or the other is. And that's what we need to understand. One or the other is. And so if you're not returning a child abuse diagnosis in these court cases, you're misdiagnosing child abuse. You're missing it. And so the child is being abused for a fact because we are not taking the proper response. Diagnosis guides treatment. The treatment for cancer is different than the treatment for diabetes. The treatment for child abuse by the targeted parent is different than the treatment for child abuse by the allied parent. The treatment is to protect the child, so it's a protective separation. From which parent? That's the question. That's the question we need answered. So, from the targeted parent's side, the question is there attachment suppression towards a normal range parent? Are these protest behaviors present? And is there a shared persecutory delusion? Now, I gave you an additional 12 associated clinical signs with this. They're pretty neat. They're pretty wonderful. And I didn't do a lot of talking about them. They're on page 3. Because again, I want to avoid that lie. It's a lie that I have some sort of new theory or no. And so everything else I've done is based entirely on the established knowledge. I have applied nothing that I know. And I know other stuff, but I'm not using any of that in solving this because I don't want to fight about it. This isn't about Dr. Childress. This is about Murray Bowen and Salvador Minuchin and the DSM-5 and real stuff, okay, that we can hold them all accountable to. The 12 associated clinical signs, though, I had to, they're mine, okay, so I gave them to you. And what I describe this as is that I'm basically, with an attachment-based model, I'm calling my home run to the left field pavilion. Okay. I'm saying these 3 symptoms are going to be present. And now that's a model of a pathology that makes a prediction that is falsifiable. Is it true or not true? That's the scientific method. So collect the data and find out if I'm right or wrong. Don't argue about me. Collect the data and it will either prove me right or prove me wrong. Dorsey Pruder has collected the data in 46 families. I'm proven right. Okay, so yeah, so I'm right. Everything I say is absolutely true and correct. We need to stop fighting about it. If you don't believe me, collect the data yourself. Each individual mental health person, is this in your patient, is this present or not? A research study of N of 1. Collect the data first. See if it's present. The 12 associated clinical signs are just choice. The use of the word forced, my parents fake, parental replacement, exclusion demand, diagnostic indicator 3. But they're not diagnostic because they're not always present. Often present. The article Greenham, Childress, and Pruder is really wonderful. Tells how often these are present in the family. And there's at least when the 3 diagnostic indicators are present, there's at least 5 of these all the time. and more likely 9 to 12 of these. 9 to 12. I nailed the predictions on this. Some of them are there 100% of the time. Okay, so this again, this is a scientific method. The model makes a prediction. Now collect the data, and is the prediction confirmed? Yes, it is. If you don't agree with Dorsey's data that in the Greenham article, then collect it on your subject. N of 1. Are these 12? How many of these 12 associate clinical signs are present? If the diagnostic indicators are present, we're expecting at least 5, more likely up around 7, 9, maybe even higher on these. These are useful because they're not always present. These are useful to confirm the others. So if you got the 3 diagnostic indicators and 6 of these, yep, that's a pathology. There's no doubt about it. 0 doubt if you've got the 3 diagnostic indicators and 4 to 6 associated clinical signs. So it confirms, helps support and confirm the diagnostic. The other thing is kind of like a screening. So if you're talking to somebody and they say, well, I can't force the child to go with the other parent, use of the word forced. Okay. Or if you see the exclusion demand come in, the child is excluding the normal range parent from their soccer games. I don't want my parent, it stresses me out. I don't want them to attend my soccer games. Number 3, exclusion demand. Now, it's not always present. Number 3 and number 4, parental replacement, they're not always present. So they're not diagnostic per se. But when 3 or 4, the exclusion demand or parental replacement is present, it is 100% diagnostic. I would say almost 100% because I don't have the data, but theoretically, based on the application of why those symptoms are associated, if those symptoms are there, then you're going to find the other 3 diagnostic indicators. So we just have them complete these. I think these are really, really neat as well. I think the whole thing makes for wonderful research about looking at why, because each one of the the associate clinical signs has a reason for it being there. Okay, so if you find it, that tells you something about the nature of what's going on inside. So number 11, that the targeted parent deserves to be rejected. If you get that theme, why are you rejecting the parent? Well, they deserve it for some past failure or something, and they're a normal range parent. They deserve to be. That's the spousal abuse theme. That's the absence of cruelty or the absence of empathy that leads to the cruelty. That it's okay to be cruel to people if they deserve it. And then they go around and decide who deserves their cruelty based on whatever criteria they come up with. That's not the real value. The real value system is we're not nice to other people because of who they are. We're nice because of who we are. And so that idea that the other person deserves cruelty is the spousal. Yeah, of course I hit her. She deserved it. My dinner was cold. She deserved it. Yeah, I slapped her around. She was talking back to me. She deserved it. That's a spousal abuse thing. So if you see number 11 there, then the spouse or partner abuse psychological diagnosis begins to elevate higher in the concerns. So that's a diagnostic checklist. I think all mental health people should routinely collect it, whether you agree with Dr. Childress or not. This is the argument of the targeted parent to the court. So whether you agree or not is not really relevant, mental health person. You're being asked to complete these symptom checklists. It's like if you send a BASC or CBCL, a symptom checklist to a teacher to get an ADHD diagnosis. So you send them a behavior rating scale symptom checklist to the teacher. I'm sending a symptom checklist to the mental health people. Complete the symptom checklist, please. If they say no, it gives you an indication that they are not competent. Then they're going to flee and run. If they complete it, then you're going to get the symptoms that identify the pathology. And the other thing is, it's so simple. Parents, you can see these. Does a child show these 5 narcissistic symptoms? Yeah. Does the child have a delusion? Yes. Does the child have? Yes. Well, then they got the pathology. Your attorney can use it. The only thing is we just need the mental health person to document that. And that's just to get at the level of it's a child's psychological abuse diagnosis. Okay. That's all we need to reach is that level if it's a child psychological abuse diagnosis. The moment we get that, we can then move into a child protection response and we have an accurate diagnosis. And our treatment plan can adjust to the accurate diagnosis. And all they need is the backbone to do it. They're not doing it, so we have to leverage them into competence because they are ignorant like a rock. So now let's switch over to the parenting practices rating scale briefly. So this is the companion one to this one, and it answers the first thing: is this a normal range parent? That's the critical question. So our first rule out diagnosis, since it's going to be child abuse one way or the other, our first rule out is the targeted parent an abusive parent, because that's the most dangerous thing. So let's rule that out first. Is the targeted rejected parent abusing the child? If they are, tell us what the child abuse is: physical, sexual, neglect, psychological. What is the child abuse going on, so we can put it on a treatment plan, fix it, and fix the family. So we never leave a breached attachment bond. We fix things. So if it's child abuse, tell us what. So, and if it's not, though, tell us that as well, so we can stop fighting about whether or not this parent is causing the child's pathology. Either they're a normal range parent or they're an abusive range parent. Either they are causing the child's pathology or they are not. And so tell us what your opinion of their parenting is. And there's ways to interview the child, interview the allied parent, interview the targeted parent about what the parenting practices are, applied behavioral analysis, behavior chain interviewing, determine whether or not they're an abusive parent. What I did was I classified parenting into 4 levels: abusive, clearly abusive range, almost abusive, not quite acknowledged abuse, but boy, it's pretty bad. That's level 1 and level 2. Level 3, it's problematic, but it's normal range. This is a normal range parent, but we would encourage maybe a little bit better parenting. So it's problematic, normal range. The fourth category is normal range and healthy. So normal range and healthy, normal range problematic, severely problematic, close to abusive, and abusive. So levels 1 and 2 would be considered abusive range parenting. Levels 3 and 4 would be considered normal range parenting. Then I also put each of those levels into subcategories of type of problematic parenting. So overly strict or overly hostile, overly disengaged, overly intrusive. And then they run across the levels. So there's overly hostile, and then there's normal range that's kind of a little angry, and so they match up across levels. But so tell us what specifically, what if there's a problem, tell us what the problem is. Because right now it's very vague, and the targeted parent can never defend themselves because they're never being told what their problem is. And there is no problem. That's why. They're a normal range parent. They're a level 3 or level 4 parent. At worst, level 3, most likely level 4. And so they're a normal range parent, but everybody's accusing them of abusing the child, and they have to continue. So let's document it once and all. Let's get clarity. If they are level 1 or 2, if the targeted parent is level 1 or 2 abusive, then that becomes the treatment plan. They're an abusive range parent. That I don't care about alienation or anything else going on. If they're abusing the child, that's the treatment plan. If, however, the targeted parent is level 3 or 4, a normal range parent, then they cannot be producing the child's symptoms. Boom, boom. If the targeted parent is normal range and the child has these symptoms, there's no other explanation other than the shared persecutory delusion, diagnostic indicator 3, and factitious attachment pathology imposed on the parent, on the child, by a narcissistic borderline dark personality parent. That's the only explanation if these two come back in that pattern. So ask your mental health people, please complete these for me. These are not assessments. These are data documentation instruments so we can stop fighting about things. And if you're going to court, you need this symptom information, and you need this symptom information based on the recommendation of Dr. Childress. So I am recommending your mental health people complete these, please, because we need these. And if you're going to consult with me, in the future, you got, July or August appointment or something, collect these, please, get them from your mental health people, or ask them and get them to say no, so you can get an idea that they're not competent and they're a problem. I can tell you they're a problem already, but because they're all a problem. The system is switching around. And during this paradigm shift, as we move from a lackadaisical, inaccurate, lazy, ignorant, incompetent approach to the pathology in the family courts, to the APA ethics standards for competence and the application of established knowledge at a high level, I'd say mastering, not just family, let's master family therapy at a high level. We return back to established knowledge and standards of practice that identify, diagnose the pathology as child psychological abuse. That's a big switch. That for 40 years, this has not been diagnosed as child abuse. And all of a sudden, everybody's going to recognize, oh my gosh, this is child abuse. Right. So you've been misdiagnosing it for 40 years. So all these forensic psychologists currently over here, all of them misdiagnosed the pathology for 40 years, or however long they've been here. They've been in the family courts for 10 years and have not been diagnosing child abuse. It's child abuse one way or the other. That's the only thing that creates the severe attachment pathology. So if you haven't been diagnosing it for 10 years in practice in family courts, you've been participating in the child abuse. You've been failing to protect the child for however long you've been in the family courts. And that's a fact. The moment the paradigm shifts, that's why the forensic psychologists are fighting against the paradigm shift. They do not want to apply knowledge, because the moment they do, they're ignorant like a rock. They're out of here. And they've been abusing the child, and it's all exposed. So all your top level forensic people who are, at the top level, I'm not naming names because I don't want to get in trouble, but you can just identify any top level forensic person in your community. If they haven't been diagnosing child psychological abuse during their career, then they've been failing in their duty to protect. That's a fact. And so then that will become the fact the moment the paradigm shifts. The Gardnerian PAS people, same thing. They're holding on to this outdated, stupid, made up thing instead of applying knowledge. And same thing. They've misdiagnosed the child abuse in the moment the paradigm shifts. So they do not want the paradigm to shift. They do not want the diagnosis of child abuse. Let that sink in. The Gardner PAS people do not want the diagnosis of child abuse for this pathology, because if they did want it, they'd switch over to Dr. Childress and get it right away. The moment you switch to the established knowledge, you immediately get the child psychological abuse diagnosis. They don't want it. They'd rather have parental alienation that solves nothing. They are a low caliber professional, very low. And the forensic people, they don't want it either. They're getting $20,000 to $40,000 for their forensic custody evaluations. Clinical diagnostic evaluation, we can bring that in 4 to 6 weeks, around $5,000 for a really good one. 2 opinions on it. $5,000, 4 to 6 weeks, as opposed to $20,000 to $40,000, 6 to 9 months. Yeah, there's financial exploitation of the parents by the forensic psychologists. That's exactly what's going on, ignorant and incompetence. And it's being covered up by the American Psychological Association, by the Association of Family and Conciliation Courts, and by the licensing boards. How do I know it's being covered up? Because it exists and nobody's stopping it. Okay, and I've got documentation on each level. So yes, there's a significant problem that's going to be changing. Already, the New York Blue Ribbon Commission on Forensic Custody Evaluations says they need to be gone. Forensic custody evaluations need to be gone from the court. But the moment they leave, the forensic people leave, and they will leave. They'll leave because it's getting really dangerous to be ignorant and incompetent. As parents become educated, the mental health people have to be competent, and they're not, so they will flee. Or and the clinical people won't be here. So the family courts is going to kind of be metal on metal in terms of mental health situations for a while, until the paradigm shifts. The moment we start applying knowledge, then it becomes safe for the clinical psychologists to return, and that's what should happen. Any forensic people who want to remain should switch over to court-involved clinical practice. They should start diagnosing the pathology. They should start using these things, and we should start identifying the shared persecutory delusion and the factitious disorder and the child psychological abuse. It's like the cover up of the sex abuse in the Catholic Church. Stop covering it up, say it's there, acknowledge and then fix the problem so that there's no sex abuse in the Catholic Church. Don't cover it up and continue with it. Maybe bad to acknowledge what happened, but acknowledge what happened. Acknowledge the failure of forensic psychology. It was a failed experiment in service delivery to it. Acknowledge it failed, and then switch over, apply knowledge, and let's get the child abuse diagnosis, and let's get clinical psychology back, assessment, diagnosis, and treatment, and a treatment-oriented solution. Treatment depends on diagnoses. We need an accurate diagnosis. The treatment for cancer, different diabetes. If we treat cancer with insulin, the patient dies from the misdiagnosed cancer. We need an accurate diagnosis, and that was the problem. That's why nothing got fixed in the family courts, because you didn't have an accurate diagnosis. It's child abuse, and you're not diagnosing child abuse. No therapy will work unless, as long as the child is being actively abused by the pathological parent. I'm looking for my final form down here. It fell to the ground. Here it is. Here's the third form. Okay. This is really cool too. The parent-child relationship rating scale. Now, I didn't call this a behavior scale. It's a relationship rating scale. Easy peasy. 1 to 7 rating, 3 items. Okay. 1 to 7. 1 and 2 is bad. 7, 6, and 7 is wonderful. 3, 4, 5 is normal range. The 3 items are affection, cooperation, social involvement. Every day, the child's with the targeted parent. The targeted parent rates the child on those 3 items, 1 to 7. Affection, cooperation, social involvement. Really bad, really good, somewhere in the middle. And emails those 3 numbers to the family therapist. The family therapist puts them in an Excel file and begins to track those 3 symptoms. Now, those 3 symptoms are the symptoms of child psychological abuse. Child psychological abuse symptoms show up relationally and emotionally. Okay, so it's going to show up. Child psychological abuse is going to show up in the attachment system. That's the affection. It's going to show up in emotional regulation. That's cooperation. And social involvement is mood and arousal. So we're monitoring those 3 symptoms: affection, cooperation, social involvement with the child. And those will be important for treatment. We want the child to stay normal range, 3, 4, 5. So when we get the protective separation because of the child abuse, we protect the child. We get the child over kinship care with the targeted parent. We recover the child's normal range and healthy development. Then we restore contact with the abusive parent. When we restore contact with the abusive parent, we're going to want those child ratings to stay in the normal range, 3, 4, 5. They can dip to 1s or 2s occasionally, but we need them to recover. We just need the child to be normal range. as long as a child remains normal range with the targeted parent, we know the child is not being abused by the allied parent, or at least the child's handling it. If the child's normal range, they're telling us whatever that parent is doing, they're handling it okay. And that becomes part of the therapy. We can work with the child around, say, just stay normal range and everything's going to be okay. If, however, the abuse gets too much and it collapses the child, then the child's going to drop to ones and twos on those ratings. And that's the child communicating to us that the abuse is resumed. I've had to collapse into that abusive parent, but they get to tell us without throwing that parent under the bus, without being disloyal to the parent. In fact, being loyal to that parent will tell us that the child's abuse is resumed. They're loyal to the parent, they collapse into symptoms. We recognize the symptoms, we then step in again to protect the child. And that gives us the way for the child to communicate to us once we restore, as to whether or not the child abuse is resumed. So with all cases of child abuse, so I work child abuse. So if we have physical child abuse, when we protectively separate the child, we recover the child's healthy development, then when we restore with the abusive parent, we monitor for symptoms of physical abuse again, or symptoms of neglect, or parental drug abuse, or whatever the concerning symptoms were for around the abuse. We monitor again. That's what this is. This is the symptom monitoring for the child abuse. Now, all therapy should have outcome measures to it. Holy cow! All therapy. If you're doing a depression therapy, they're called SUD scales, subjective units of distress. On a scale of 1 to 10, how sad have you been this past week? On a scale of 1 to 10, how often have you felt depressed? On a scale of 1 to 10, we just use a scale of 1 to 7, called the Likert scale. And so all therapy, depression, anxiety, ADHD, whatever, should have outcome measures about, are you reaching your goals for the therapy? This, I strongly recommend this be the outcome measure for attachment pathology in the family courts. So I recommend that this gets routinely done, and I recommend that this be the routine outcome measure. The targeted parent, every day the children are with them, the targeted parent rates them on 3 items: affection, cooperation, social involvement, 1 to 7, and sends those 3 numbers to the family therapist. Family therapist puts them in an Excel file. Then during the weekly therapy session, everybody can talk about what the ratings were that week. Oh, we had a rating of a 2 on a Wednesday. What was going on, Michael? And Michael can tell his side, and mom can tell her side, and the therapist can help them problem solve, negotiate, develop conflict resolution skills, all the stuff, and monitor the accuracy of the parents' reporting as well. And so these are brought into therapy as well. And this takes the focus off of talking about the past and the situations 2 years ago when the divorce happened. Get over what's going on now, and how do we resolve it now? How do the breach and repair? It's called breach and repair sequence. Tronic right now is calling it mismatch and repair. So the mismatch and repair. And I recommend that all parents get, all mental health people get Tronics and Gold, The Power of Discord, that about the breach and repair and sloppy relationships. We like sloppy relationships. We like things not to be perfect. And so that's important. So with that, I'm going to run away to my Sunday now, and we'll see you all again next week for Coffee with Dr. Childress. Take care, everybody. Bye-bye.